Good afternoon for all. Once again, thanks Arthur for inviting me to this nice place, and it's the honor for me to be here. And I will try to tell you for a few words about the amyloidosis. You know that amyloidosis is a very rare disease, and in many countries in Western Europe, the patients with the amyloidosis are referred to centers. In one center in Great Britain, one center in Germany, in Heidelberg, one center in Pavia. There's the difference. In Czech Republic, we have many centers, and usually the patients with light chain amyloidosis are treated in the hematology departments by university hospitals. So we can start. The amyloid or amyloidosis is the disease which consists of the deposition of the proteins which have the changed structure. The exact term is in English misfolded. So these misfolded proteins have the appropriate, and they make the deposition in the tissues, which lead to disorganization of the normal tissue structure, and this leads to organ malfunction. Now we have identified more than 32 amyloidogenic proteins. Many amyloidoses are very rare, usually case reports, and many amyloidoses are more common, such as light chain amyloidosis or AA amyloidosis. You can see that the amyloidosis is a rare disease. The incidence is about 10 to 12 new patients per million per year, and usually the amyloidosis affects older people over 60 years. And basically we distinguish systemic and localized amyloidosis and acquired and hereditary. This is the basic classification for the clinical use, and you can see that the hereditary types of amyloidosis are very rare, and the acquired are more common, and the most common is light chain amyloidosis, which is treated by the hematologist, and it's one of the part of the plasma cell dyscrasias. Another types of acquired amyloidosis are AA amyloidosis. The old term was secondary, and usually affects the people with a chronic inflammatory disease such as rheumatoid arthritis, lupus, or some inborn diseases such as familiar Mediterranean fever. Wild-type TTR amyloidosis, the old term was senile, but you know that the physicians and the professors don't like the term senile, so the exact term is wild-type TTR amyloidosis, and it usually affects the older man with the predominant cardiac involvement. And beta-2 microglobulin amyloidosis is associated with hemodialysis. Hereditary amyloidosis, Czech Republic is not endemic country. You know that the most common type of TTR amyloidosis is in Portugal or Sweden or in Brazil. So many families with this disease have their country of origin. So another type which we have, which patient with hereditary amyloidosis we have, is a fibrinogen amyloidosis or apolipoprotein associated amyloidosis. Light chain amyloidosis is the part of your daily work. It is necessary to know that the light chain amyloidosis mostly affect kidneys, heart, liver, and the peripheral nervous system. Light chain amyloidosis do not affect central nervous system, and in 1/5 of the cases we have association with multiple myeloma or Waldenström's macroglobulinemia or another B-cell malignancy. What's about the pathogenesis? Some clone, a small clone, like light chain amyloidosis, or a huge clone, such as in multiple myeloma, produce unstable or misfolded light chains. They form the fibrils, and they form the deposits in the tissues. The light chains can be also toxic in their basic aggregates. Usually the toxicity is for the heart. About the symptoms and syndromes, the deposition in the organs lead in some patients in the tongue enlargement. They have the periorbital purpura, the raccoon or the panda eyes, imbibition of the joints, and they have many clinical syndromes such as nephrotic syndrome, heart failure syndrome, or some type of neuropathy, especially carpal tunnel syndrome. There are the images from from the autopsy of one of my patients. He died after 30 hours after established the diagnosis in our hospital, and you can see the changed macroscopic structure of the organs, especially the heart. You can see the concentric hypertrophy, waxy appearance of the spleen, reduction of the kidneys, and changed structure of the liver. What are the principles in the diagnosis and the treatment of the light chain amyloidosis? About the diagnostics, biopsy of biopsy proof of the amyloidosis with exact typing. The establishment of the diagnosis of the amyloidosis is based on the biopsy and immunohistochemistry with the exact typing of the masses. We must know which protein is involved in the amyloidogenesis in each patient. In case of light chain amyloidosis, the second step is the proof of the monoclonal plasma cell population with the detection of the product of these plasma cells, serum free light chains or molecules of the paraprotein, assessment of the organ involvement, especially heart, because the heart involvement is the most limiting factor for the patients, and exclusion or confirmation association with the multiple myeloma or another disease. And in case of therapy, the individual choice of the therapy is necessary in each patient's choice of appropriate chemo or immunotherapy, and careful indication of the stem cell transplant. Supportive therapy, you need the cardiologist, you need the nephrologist, neurologist, nutrition specialists, and indication of the organ transplantation. You know that the heart transplantation is now very intensive in whole Europe, and we have also many patients with the heart transplant. About the detection of the monoclonal proteins, you know that in multiple myeloma, the serum free light chain assessment can replace the Benz-Jones urea studies. But in light chain amyloidosis, many patients have very severe nephrotic syndrome, so the light chain escaped to urine, and in these patients we measure normal or decreased levels, both kappa and lambda light chains with the normal ratio. So in case of these patients, the monitoring is only of this patient. Treatment is due by the urine studies. So the assessment of serum free light chain, electrophoresis, immunofixation, free light chain assessment, and urine studies is necessary in all the patients. Proof of the clonal plasma cell population, the light chain amyloidosis without infiltration of the bone marrow, as in multiple myeloma, is usually very difficult to detect the clonal cells. So the advantage is the multiparametric flow cytometry to assess the clonality of the plasma cells. About the cytogenetics, you know that in multiple myeloma, the translocation 11-14 is the advantage, have the neutral prognostic influence on the patient, but in light chain amyloidosis, the patient which are carrying translocation 11-14 have the worst prognosis and usually don't have intact immunoglobulin, and the overall survival and progression-free survival is not so good if we are treating by the bortezomib-based regimens. And also the patient with gain on 1q21 do not profit from the Meldex treatment. There are the curves from the Heidelberg, and you can see that patients which are carrying translocation 11-14 do not benefit from the treatment. bortezomib and have the lower overall survival. And the changes which are associated with a bad prognosis in multiple myeloma, such as for 1416 or the L70P, have no bad influence on the overall survival. What about the detection and the typing? Many patients have multi-organ involvement. More than 1/3 of the patients have the involvement of more than 3 organs. So the biopsy of the involved organ is not necessary. So it depends on the experience of the center. In our department, we use abdominal fat tissue for the screening, for the detection, and for the typing. It is the least invasive, not harmful for the patient. Many centers use rectal biopsy, bone marrow biopsy. You provide in all the patients because you need trephine biopsy for establish the diagnosis of multiple myeloma. And if you have these untargeted biopsies negative and you have the highest suspicion for the light chain amyloidosis, so you provide organ biopsy such as kidney, liver, or the heart biopsy with higher yield of the exact diagnosis. So what about another amyloidosis? In case of AA amyloidosis, AA amyloid usually affects kidney, so the kidney biopsy is necessary. In the mutated TTR amyloidosis, TTR amyloidosis is not usually visible in the fat, so the biopsy of the heart or the gastrointestinal tract is necessary. In patients with fibrinogen amyloidosis, so usually the kidney biopsy or aspirate is used for the establishment and typing of the amyloid tissue. What about the detection? The gold standard is Congo red staining with the salmon-like deposits in the direct light and the green birefringence in the polarized light. And you can also use another staining with the hematoxylin or thioflavin T for the immunofluorescence. The view from the fat tissue aspirate, we use it in a daily practice, is usually easy, and we have 4 grade grading. We evaluate, 2 doctors evaluate the smears of the fat, me and the pathologist. So we have the same grading, so we establish the diagnosis of the amyloidosis. What about the typing? Currently, the typing absolutely necessary. First step, immunohistochemistry or immunofluorescence, and if we are not successful, so the proteomics is the gold standard. About the immunohistochemistry, success up to 94%, but it is not very sensitive in case of light chain amyloidosis because usually the commercial available antibodies against the lambda and kappa light chains are used. So you need to detect misfolded light chains, not normal light chains. So this is the disadvantage of the immunohistochemistry in case of light chain amyloidosis, but another staining for AA or TTR is very robust. There are a few slides or images from our pathology. The immunohistochemistry with the antibodies about kappa and lambda light chains against AA amyloid, against transthyretin, and if you are not very sure if the Congo view or the image in the microscope is amyloid or it is not amyloid, is it collagen or is it collagen, you can use the staining for the SAP compound for the detection of the amyloid. In case of light chain amyloidosis, few images from our pathology, kidney and the involvement of the tongue. In case of fibrinogen amyloidosis, especially involvement of the glomerulus and also the immunohistochemistry, antibodies against the fibrinogen. AA amyloidosis, again kidney, and TTR, the myocardium, and this is the biopsy from the stomach. Immunofluorescence, the disadvantage of the immunofluorescence is that you need a fresh frozen sample. So when we get the sample from another center, from another hospital, we usually have the paraffin embedded sample, don't have the frozen sample. But when we have or get the frozen sample, the immunofluorescence is more sensitive than immunohistochemistry in case of light chain amyloidosis. So when we have the patient in which we provide kidney biopsy, liver biopsy, or heart biopsy, we send the sample to the immunofluorescence. And also in Olomouc, as in one center in Czech Republic, we have the mass spectrometry. We have the two different types of the mass spectrometry. The first is that we evaluate the slides with the paraffin samples. So for the first, by the laser microdissection, we isolate the Congo positive masses, and then we provide amyloidosis by the mass spec, and our doctor sent me the results with all the proteins which are involved in the amyloidosis, and the mass grading tells you which kind of protein is involved in the amyloidogenesis. And another type of mass spec typing of the amyloid we provide from the mixed tissue from the abdominal fat biopsy. We have the mixed sample of the fat, and from this sample we can provide not only detection of the amyloid but also the typing is very fast. It is not cheap, but it is very, very fast, and if we have sample not older than 24 hours, we can provide the typing from the abdominal fat tissue biopsy. What about the staging? We have two staging systems. Both are from Mayo Clinic. They are based on the levels of the cardiac enzymes or biomarkers, troponin T or troponin I, and NT-proBNP. The new staging system published by Saji Kumar is based also on the levels of the serum free light chains, but in the clinical practice is used the older, published by Angela Dispenzieri. There are several other staging systems. European Myeloma Network established European staging system of advanced cardiac involvement, which involves also the levels of the systemic blood pressure and the high levels of NT-proBNP. So we have the grade 3 by Mayo and ABC by European Myeloma Network. And renal staging systems, you know that the patient which have severe nephrotic syndrome over 10-12 grams per day, if you are successful with the treatment of the amyloidosis and the patient reach the hematologic VGPR or complete remission, usually the proteinuria remains very high for months and years, and usually the proteinuria is also, high proteinuria is also risk factor for the dialysis in the future. About the heart involvement, about 2/3 of the patient with light chain amyloidosis have heart involvement, and about 1/3 of the patients have symptomatic heart failure in the time of diagnosis. So heart involvement assessment is crucial for the determining treatment strategy and overall survival of the patients with 3B, 3C. Heart involvement is about 1.5 of a year. So again, cardiac biomarkers not only for the staging but also for the detection of the heart involvement and for the assessment of the therapeutic response. Also NT-proBNP, but in patients which are treating with IMiDs such as lenalidomide, thalidomide, pomalidomide, the levels are of NT-proBNP are during the treatment artificially increased. And in case of troponins and also to NT-proBNP, if you have patient with renal failure, the levels are overestimated. Echocardiography for the screening. In many cardiac ambulances, the definition of the heart involvement is hypertrophy of the interventricular septum over 12 millimeters, and can assess the function. And in our laboratory, the cardiologists have many other techniques I cannot explain, such as strain or speckle tracking. And also magnetic resonance is very sensitive and specific for detection of the amyloid involvement of the heart. You can also assess the patient with the renal insufficiency by T1 mapping without the contrast of gadolinium. In many patients which have the suspicion for the heart amyloidosis and have the normal serum-free light chains, and cardiologists send you the patients for the biopsy, and you think about the heart biopsy, you can also use DPD scan for the detection of the transthyretin affection of the heart. DPD scan is usually negative in patient with the light chain amyloidosis. So now you can use DPD scan for the established diagnosis of senile or wild-type TTR amyloidosis in many patients without need of the heart biopsy. And you have the suspicion from the echo magnetic resonance, so you can use DPD scan. What about the treatment strategy and the response assessment? There are the curves from the London. You can see that during the years, the treatment successfulness or the overall survival of the patients is slightly improved, but about 1/3 of the patient died in few months after the establishment of the diagnosis. The similar samples you can see from the Mayo Clinic. You can see the 1/3 of the patients in about 15 years period die few months after the diagnosis establishment. So the prognosis of the light chain amyloidosis is a little bit improved in the last year, but we missed many patients because usually the patients came late to the physicians. What are the principles of the treatment? You have the clone, which produce amylogenic light chains, especially lambda and kappa, which leads to organ involvement and to limited survival. So you need the treatment which lead to hematologic response, to stop the production of the light chains kappa and lambda, and after we reach the hematologic response, we can wait for the organ response and the extended survival of the patients. There are validated criteria for response assessment. For the hematologic response assessment, the tests are mainly based on the serum-free light chain assessment, and in patients with the heart or renal involvement, we have also the staging system or assessment system for definition the organ response. Which is the therapeutic goal. The VGPR is based on a work by Palladini from Italy, and the approach of the treatment may lead to reach at least VGPR, better CR for the extended survival of the patients. And which treatment is the appropriate to reach VGPR? You can see that the autologous stem cell transplantation is very successful. Melphalan dexamethasone is very active. Bortezomib-based regimen may be the same, such as high-dose therapy, and IMiDs are not so successful as in multiple myeloma. High-dose therapy with autologous stem cell transplantation, there was only one randomized trial which was published by a French group comparing melphalan plus dexamethasone and the high-dose melphalan plus autologous stem cell transplantation, and the result was that the melphalan plus dexamethasone was better for the survival. But this study involved many centers without the experience with the transplantation of the patient with light chain amyloidosis, and also with no stratification and appropriate choice of the patients for the high-dose chemo. Next study, which was the comparable study published by Mayo Clinic, preferred the high-dose chemotherapy over the melphalan dexamethasone. Now, only one-third patients with light chain amyloidosis is suitable for the high-dose chemotherapy, and the 10-year survival is about one-third of the patient, and patient which gets or reach the CR in 53% live more than 10 years. And when we use this exclusion criteria, the treatment-related mortality decreased to 7%. There are another regimens which can use, and we can see which response, hematologic or organ response, is associated with each of the regime. Also, the benefit of the risk-adapted high-dose chemotherapy. Many patients, about 80% of the patient reach response with 60% of the clone CR, and about 70% of the patient reach the organ response. So you can see the benefit of the high-dose chemotherapy. This is the schema from Mayo Clinic, which we use in our daily practice in our clinic. So if the patient is transplant eligible, we use the induction of Cybor-D in all the patients. In our clinic, we give the induction for all the patients, not only the patient with over 10% of the plasma cells in the bone marrow, and then we refer this patient to the high-dose chemotherapy. Patients which are not eligible for the high-dose chemotherapy, we use Cybor-D senior or B-MELDEX, and in the patient with the severe heart involvement with the heart failure, we use only bortezomib and melphalan, or bortezomib with cyclophosphamide without the steroids. And therapeutic goal is the VGPR in these patients. This is a schema for the refractory patients. If the patient don't have first line bortezomib, you can use bortezomib. If the patient don't have alkylating agents, you can use alkylating agent. And in the patients which are bortezomib refractory, you can think about the lenalidomide or pomalidomide. I have only 2 patients with light chain amyloidosis which I treat with the carfilzomib, and I have no experience with the daratumumab in the patient with light chain amyloidosis. This is the new schema from the European Myeloma Network, which was published before the Christmas last year, and it's probably the same as in Mayo Clinic. So, but the patients which have translocation 11-14, the standard treatment will be melphalan dexamethasone without bortezomib. Patients which have gain of 1q21, cyclophosphamide, bortezomib and dexamethasone, and if the patient have high levels of the serum free light chains, the treatment in combination with bortezomib will be successful in these patients. Ongoing studies, many new drugs such as ixazomib, pomalidomide, carfilzomib, daratumumab, venetoclax are now involved in the phase 1, phase 2 studies, and also the new antibodies-based regimens are used, and I will speak about next. And there are the curves from the daratumumab treatment, and you can see that the daratumumab-based chemotherapy in a heavily pretreated patient with light chain amyloidosis was successful in many patients. What about the perspective therapy? There was the drugs which we used to kill or to stop or to reduce plasma cell population in the bone marrow, but we can also affect the fibrillogenesis with the doxycycline or the green tea derivates, and you can also target the amyloid deposits by the monoclonal antibodies. The first known antibody was anti-SAP treatment. It was developed by the colleagues from Great Britain, and the antibodies are targeted against the SAP, serum amyloid P compound is the basic compound of all amyloid masses, not only light chain amyloid, but all the amyloid masses. So the treatment with anti-SAP is targeted on the SAP, which is deposited in the amyloid tissue. The problem is that the patients, and usually normal population, have high levels of the circulating SAP in the plasma. So the first step is the depletion of the SAP in the plasma of the patient by miridesab, and after we deplete the levels of the SAP in the plasma, we can use the treatment with anti-SAP treatment. So there are the slides from the SAP scan, and you can see that after the administration of the anti-SAP antibodies, we can see the reduction of the deposits of the radiopharmac in the liver. There are the reports of the successful treatment from the patient with the dominant liver involvement or kidney involvement, but the patient with the dominant heart involvement, there are still no the data from the long term the studies. The second one antibody was the NEO-D, which was targeted to the misfolded light chains. It was against the light chain amyloidosis. The first reports were very good, and they referred about the response about the organ response in patients with cardiac and renal amyloidosis. But in April 2018, the Protena discontinues development of the NEO-D, so the NEO-D development is now stopped. And the last one is the bispecific antibody against the light chains. It's also for the light chain amyloidosis, which binds to the light chain fibrils and also to the macrophages or neutrophils. So we have the reports from the phase 1 and phase 2 studies, and we can see that about 63 and 70% of the patients have organ response, cardiac, renal, and also gastrointestinal response. So this antibody seems very perspective for the treatment of the patient with the light chain amyloidosis. Veka reports that the addition of the doxycycline in the treatment of the patient with advanced heart involvement 3A or 3B reduce the early mortality and lead to the better survival of the patients. We use this drug in treat all the patients. It is very good for the as an antibiotic prophylaxis, but usually doxycycline is not it is not a friend with the warfarin. So in patients which have warfarin, we don't use doxycycline. About the venetoclax, there are a few case studies or case reports about the treatment with the venetoclax, especially in patients which are carrying 11-14 translocation. And about the IgM-related amyloidosis, IgM-related amyloidosis is a little bit different from another type of the amyloidosis. It is usually associated with Waldenström's macroglobulinemia or chronic B-cell leukemia or marginal zone lymphoma, and usually the patient have affection of the heart and lung and have the lymph node infiltration by the amyloid node, by the plasma cell or another B cell cells, but by the amyloid. And the treatment is very difficult. It's very difficult to reach at least PR in these patients. So all paper reported that the ibrutinib is not suitable for the patient which have IgM-related amyloidosis, but the colleagues from the Great Britain refer that rituximab with bendamustine can be successful in these patients. So thank you very much. And if you have any questions?